Hi all, just wanted to go over last week's work, this week's work to come, and our quiz from last week. Hopefully everyone had a restful and reflective Memorial Day weekend, and hopefully we can dig into the last few weeks of our course and get through the rest of this first summer term. It's crazy to think we're in week 5. I keep saying that each week, but weeks go by like days anymore for whatever reason. So last week we looked at social responsibility a little bit, resource allocation, ethics in marketing and managed care, just a few different areas that are important to consider from an ethical standpoint. And hopefully, as you're understanding by now, moving into week 5, that I think a lot of people, especially those of you that come from clinical backgrounds, a lot of people really focus on ethics, bioethics, or ethics related to clinical medicine. And there are so many other aspects of ethics that we deal with in the healthcare setting as administrators that have nothing to do with bioethics or clinical ethics at all. So, there's so much more that we deal with from a justice, distributive justice, or business ethics standpoint that are so important to our industry. If you have someone leading your organization that abuses their authority or acts inappropriately from a social responsibility standpoint, or any cadre of different things, that's just as bad as people that act unethically from a clinical standpoint. So it's important that we're keeping in mind all of those different pieces. So this week we actually will look more at the common bioethics or clinical ethics type situations, consent, death and dying, patient autonomy, physician-assisted suicide, all the different areas that if you were in our undergraduate program, you've already studied with me in our law and ethics class, but hopefully at a slightly deeper level than we looked at in the undergrad setting. So digging into some of those areas, we do have a case study for discussion this week, and there's also a case study for our assignment, and I think that that there's the whole aspect of these case studies really gives you a better, lets you dig into a topic and explore your thoughts on the topic as it compares to the information in the case study. But in many cases, outside of legal requirements, there is no right or wrong answer to much of these things. So, so just keep that in mind. We also have a a lecture that's optional with regard to consent that's posted this week, and then we have our quiz as we always do. So, so that is week 5. So let's hop over here to our quiz questions for this past week. So the first question: no margin, no mission means. So the answer is the organization must realize a profit in order to have funds to accomplish its mission. So that's generally what it means. You have to, in order to do those mission, to really do a good job at those mission-based activities, you have to be making a profit. There's a kind of a misnomer that a non-profit organization doesn't make profit. Actually, hopefully it does make profit. Many of them don't, unfortunately, but hopefully it does make profit. And the purpose of a nonprofit is to take that profit that they've made and turn it back around into the organization, into its mission, into meeting those objectives. Very different than a corporation, that a for-profit corporation that would then turn that around and distribute to its shareholders, or even a for-profit business that would then take that profit and pocket it, because that's what they're there for, is to make money. A not-for-profit is very different than that. And so interestingly, the other answer that most people chose if they didn't choose C was D, A and C. So A, the organization can abandon its mission if it has no margin. Think back to any of your finance related courses that you've had already, and think about nonprofit status. So the majority of healthcare organizations are not-for-profit organizations, and a part of maintaining your not-for-profit status is to have those mission-based activities. Let's say if you're a healthcare organization, you need to reinvest in your community, you need to do all of these different things, and if they don't do that, then they lose that not-for-profit status. And for those of you that are in the Western PA area or were at some point, you might remember several years back where the city of Pittsburgh took UPMC to task in that they didn't feel that they met the criteria as a not-for-profit organization. They're making billions of dollars each year, and they're not necessarily turning around as much into the community as the city of Pittsburgh felt that they should be. They were closing down hospitals in areas that were that it was the only facility in the area. The CEO makes a very large amount of money, larger than pretty much almost any other nonprofit CEO. So there was a lot of question there, and as it came down to it, they were counting the write-offs that they make for Medicaid. So let's say a service costs $150 and Medicaid pays $10 because Medicaid plans notoriously pay poorly. They were counting that $140 write-off as charity care, which it really isn't, because Medicaid is a contracted plan. You can choose not to participate in the Medicaid program. That's a contractual write-off that you've agreed to. It's not like providing free care to people, which is truly charity care. So there was a lot of back and forth with regard to that. Not to say that UPMC does great things for the community, and a lot of that, honestly, is driven by their employees. A lot of UPMC employees do volunteer work in the community. They provide free care to patients. They do a lot of that is driven at the grassroots level, which is awesome. It's not so much driven from the C-suite, unfortunately. But so an organization could never abandon its mission if it is a not-for-profit organization, which most healthcare organizations are. So that's why A is incorrect. C is the most correct, because in order to accomplish that mission, we could never abandon it, but in order to be successful, in order to accomplish the mission, you're going to have to realize a profit. So hopefully that makes sense. If you have questions on that, please just let me know. And that's a very common no margin, no mission. I think I heard that the first time in the 90s when I went to work for a Catholic hospital, and it was always about a group coming to us, and I worked in finance, group coming to us and asking us for funds for some mission-based activity or another, and this was the CEO's, one of the CEO's favorite, or CFO's favorite phrases. So it's still today a problem for organizations, and they struggle with especially those that are right on the teetering edge of being able to make a profit or not. How do they fulfill that mission? Next question. The law that makes no distinction between citizens and illegal aliens in receiving emergency treatment is, and so that is EMTALA, the Emergency Medical Treatment and Active Labor Act. And all patients that come to an organized emergency department or a facility that has an organized emergency department have to be provided a medical screening exam by a qualified healthcare practitioner to determine if they have an emergency condition or not. And then that patient needs to be stabilized before they could be moved out of that facility. So although any of us that have been to the emergency department or have worked in the emergency department know that oftentimes patients are asked about their insurance, their registration information, all of that in advance of perhaps receiving that screening exam. That tends to be more for administrative convenience. They could not ever turn you away for that medical screening exam and if it was determined that you did have an emergency medical condition that required stabilization, they would have to stabilize you regardless of whether you are a citizen of the United States, a citizen of another country. It wouldn't matter, illegal in this country, none of that matters. So they do have to stabilize you. The issue that comes into play with EMTALA is once the patient's stable, do they stay on in-house if they have no insurance coverage or no way to pay, or do they get moved to a different public facility, which tends to be where the questions come up when it's a private. For example, I worked at a public hospital. It was owned by the state of New York, and oftentimes we would get patients that were stabilized at the local private hospital, which was known as the Spa on the Hill, which was a very nice hospital. Our hospital was also very nice, but it was in a very wealthy area of town, and sometimes patients would end up there that had no insurance and would eventually, ultimately, come to us after stabilization because that hospital on the hill was not interested in keeping them, keeping them past stabilization. So once they're stabilized, they can be transferred to a more appropriate facility, and there are lots of other times that transfer is appropriate under EMTALA, but just the basic look at it is generally facilities do have to provide that. They do have to provide the quality of the medical screening exam and then stabilize the patient under EMTALA. Next question. Competition in healthcare blank, so lots of different options, is the same as competition in any business? No, definitely not. I'll move down to C because that's also incorrect. Can lower healthcare costs because patients can choose their providers? Actually, no. Competition in healthcare tends to drive up costs, which makes it very different than any other business. And I think we can see that in the, again, for those of you in the Pittsburgh area, it's very easy to see there with the high level of competition. But if you're not in Pittsburgh, if you're in another area where you see a intense rivalry like there is between UPMC and AHN, you'll see that same issue there. Here in Orlando, where I live, we have a similar rivalry between Advent Health, which are the kind of the big guys on the block, and Orlando Health, which is a smaller regional firm, regional organization. Advent used to be regional and is now working very hard to be a nationally recognized healthcare system. So it does drive up costs and it drives down service, unfortunately. So that makes C wrong as well. So B is correct. Can cause duplication of services because that all you need to do is look at any situation. In most towns, you'll see it if you have an intense rivalry between healthcare organizations where one's building a hospital on one corner and the other one's building a hospital on the corner across the street, and which is insane. In a state, I came from a state that was a certificate of need state, meaning that in New York you have to have a certificate of need in order to build a healthcare facility, which means the state needs to look at the community and make a determination if there is need for more hospital beds. Pennsylvania is not a CON state, and Florida is also not a CON state, so they can build hospitals wherever they would like. So it does cause duplication of services quite a bit. And then also D can increase costs because organizations compete for physician staff and patients. And you can see that in organizations that are paying $5,000, $10,000, $15,000 sign-on bonuses for positions like CNAs. Or RNs or LPNs or whatever, physicians, because they have to kind of outbid the other people up the street. So it really can cause a lot of duplication in services and significantly increase costs. So our answer to that question was E, B and D only. So that's all I had this week. If you have any questions as you're moving into week 5, please feel free to reach out. Otherwise, I'll look forward to seeing everyone in the classroom. Thanks.